Hi, everybody. Welcome back. It's Dr. Rebecca Griffith, the ED-DPT, and we are here for another episode of Admitted or Not. And I have with me today Dr. Goldberg, and I'll let you introduce yourself.
Hi, everyone. My name is Liz Goldberg. I'm current faculty associate professor in emergency medicine health services at Brown University, but will be at Colorado University starting October, so I'm very excited for that. And I'm a practicing clinician, and I also run clinical trials. Currently, we have a clinical trial funded by the NIH that leverages all the wonderful things PTs can do in the ED for older adults, and I'm excited to talk more about that.
I'm excited to talk more about that too. But first, what brought you to emergency medicine? I know it's a really competitive specialty. It's really stressful. There are some people who say I could never work in the emergency department, and other people who thrive on it. So what was your draw?
So I think my draw was that I really always wanted to take care of people across the lifespan. So from pediatrics to older adults. And I always liked that we see anyone at any time and at any cost, really. So the fact that our doors are open for people regardless of ability to pay was a draw. And then when I was an undergraduate, I shadowed a really awesome nocturnist, someone that worked only at night. And I was so impressed with just her breadth of practice, just how many complaints and concerns of patients she could address all on her own. So those are a couple of things that attracted me to emergency medicine.
I love that. I think for me, one of the reasons I like it so much is because it truly is a safety net where we're able to see anyone and everyone. And especially from a physical therapy perspective, for so many people, physical therapy is a luxury and it might be something they never encounter in their life. So to be able to provide that in the emergency department, I think is doing a service to our community. From your perspective, what do you feel like are the best skills that you need to practice successfully as a physician in this area?
I think you need to be willing and able and excited to fix and solve problems, because whether we like it or not, as emergency medicine clinicians, we often see people who don't have an easy fix. They've already seen another doctor, they've already seen another clinician, and their problems remain and have not been solved. So you have to like the puzzle work of trying to work through those problems. You have to be able to redirect people and work really efficiently. And you have to collaborate with teams. There's no way that we could have the skill set to take care of all of that on our own. So you have to be really excited about leveraging your administrative staff, making sure that you get advice and incorporate that the advice from physical therapists and pharmacists and other professionals into your practice. And if you're someone that wants to go it all alone, emergency medicine is not for you.
Yeah, I think that's true. Like you're a specialist at being a generalist on high speed.
Exactly.
And one thing I often hear patients say in the emergency department is nobody did anything for me. Can you speak to that a little bit? Because I think that's a huge disconnect in the emergency department, because it feels like nobody necessarily solved your problem. But what is the goal of coming to the emergency department?
Yeah, so I think a lot happens behind the scenes. Obviously, it takes a long time to reach out to specialists or other professionals to help a patient. A lot of it is coordinating care that somehow was not able to be coordinated before, and that takes time, and that time is not necessarily in front of the patient. A lot of what we do, I think, as emergency clinicians is also working on flow and tracking people through the emergency department and really determining, do you need this level and intensity of care, or are you better served elsewhere? And so sometimes people triage themselves to the emergency department that don't really need that intensity of care. And I think those are the folks that are most disappointed, because in order to provide the awesome stroke care that we provide and falls care and trauma care, we also need to be able to quickly wrap up visits that are lower acuity and can be better served in other settings.
I think that's really true. And one thing that I try to reassure patients with is if you're waiting, it usually is a good sign that you're going to be okay. It might be frustrating, but you're going to be okay. And we're going to do everything we can for you while you're here. But my goal as a physical therapist in the emergency department is to get those patients out. Whether that's back home, whether that's home with home health, whether that's to outpatient or inpatient rehab, or even admitted to the hospital. So when I talk to students about how to work with patients in the emergency department, the key really is out. it doesn't matter where it matters. I mean, it does matter where, right? It's the next best place for them. But my
Hmm.
goal is to safely and most efficiently, with the best quality care I can, get them to that next step.
And that's one of the things I value the most in the physical therapists that we work with and in our clinical setting is that physical therapists are really great at discharge planning. They're really great at understanding what the patient's going to need once they're home and helping them come up with those resources and helping them build their strength so they're able to work within their current environment. Um, Also, just the assessments that physical therapists do help them decide, do you need to be admitted to a hospital? Do you need to go to a rehab facility? Are you someone that can just go to like a community-based fall prevention program to build your strength? What is the right next step in your care? How do we help you find that?
Yeah, and helping people, I think, understand why that's necessary too.
Mhm.
We can talk about that in a little bit, but I'm curious how you became involved with physical therapy in the emergency department. It's not as common as I'd like it to be. And whenever we have new residents or new attendings, they're like, wow, this is like a gift. Where did this come from? So how did you come to be involved with PT and ED?
Yeah, so I have to say, during my medical school and residency training, I really didn't interact much with physical therapists.
Mm,
We didn't have a PT model in the ED when I was training, and so I really came in with very little knowledge of what PTs do, other than I knew that they saw patients after injury sometimes. And so how I got more involved is I was talking to our case managers one day because I was interested in kind of pivoting my research program to geriatrics. And I was talking to case managers and asked them, what do you think we really need in the ED to help our older adults and help us kind of work up their chief complaints and improve the care we provide to geriatric patients. And they said, really, what we need is physical therapists, and here are the
mm,
reasons why. And that's when I realized everything that I'm doing in the future has to be really multidisciplinary and really should include PT
yes.
in the team.
Awesome. And so how did that lead you to your research? Again, can you tell us a little bit about what you're exploring?
Yeah. So what I designed was an intervention called gap care. So it's a geriatric acute and post-acute fall prevention intervention. And the idea was, currently the status quo for older adults that come in after a fall is that they get a head to toe trauma assessment. And we were pretty good at doing that. We have a very strict ATLS protocol that we follow. And I think we're very good at assessing, what needs X-rays, what needs a CAT scan, and where are the injuries. What we don't do a great job of in the emergency department, and this is nationwide, not just here in Rhode Island, is assessing why did people fall. And it turns out
Mm,
most falls are preventable if we can determine the reason why they fell. And so in order to determine those risk factors, we have to ask additional questions, and really it'd be great to bring PTs and pharmacists to the bedside to help us start to modify those risk factors. So what gap care is a fall prevention intervention that is multidisciplinary, involves PTs and pharmacists in the care of ED patients right after they fall in. And the idea is that older person goes home with an action plan of how they can, in the case of PT, improve their lower extremity strength and their balance and improve their home environment to make it less likely that they fall again.
I think I would be remiss on behalf of my occupational therapy colleagues to ask why they are not included in this protocol.
Yes, I think only because when I spoke to the case manager, the first thing out of her mouth was, we really need to include PT. But I think
Mhm.
occupational therapy has a really great role in this. And the way that we work it here at our hospital is that typically PT is the first touch point, and then they'll
Mm.
say, this patient could really benefit from OT, um, and they've helped to educate us on what OT does.
Yeah, I could see a role for them with cognitive assessment, with assessing how patients are doing their activities of daily living, looking at their
Hmm.
pacing, their safety
Hmm.
insight, all of those things, which we do look at, but they really truly are subject matter experts in that area. I think OTs can also offer a lot of insight to caregivers and like best ways to help facilitate that patient doing as much as possible for themselves. Because I think sometimes as physical therapists, we have a tendency to be a little too safe and to be like, oh, you need to like guard this patient all this time and they need to always use the walker. And when sometimes patients I think my microphone's cut out a little bit here. Let's see. Oh no, here it goes. Better. So I would think that just as for a future state, adding occupational therapy to that would be great.
Yeah, that's a great tip. And I've heard that from others too.
So what have you found so far? Do you have any preliminary data you can share with us about how things have been going? Or what
Yeah, so
stage are you at in this research?
we completed a pilot already. The pilot was funded by the National Institutes of Aging. I just want to acknowledge their support for this.
Love
And
it.
essentially it's a clinical trial. It was a randomized controlled trial of 110 patients where 55 patients received the gap care intervention. So they were seen at the bedside by both PT and pharmacy in the ED, and then followed for 6 months to track their outcomes. And the other 55 patients received a brochure about home safety from the CDC, detailing, what they can do to make their home safer. And what we found is that the patients that received the gap care intervention had 66% less ED visits for falls in the 6 months after their initial ED visit for the fall. So basically, we reduced visits for falls, and we also reduced all-cause ED visits. And I think the reason for that is that this is really a care transition intervention. Instead of ambulating the patient and saying, okay, you can walk here in the emergency department, so we're going to send you home. Instead of doing that, our PTs were able to recognize if someone wasn't safe to go home and instead, needed to go to SNF, or if they weren't safe to go home without resources and needed outpatient PT. And then our pharmacists would meet with the patient, and they would also, point out medications that increased fall risk. And then all of that information was faxed to the primary care doctor at the end of the ED visit so that the primary could make those changes as well. So we were communicating better with the primary care physicians. We were communicating with the patient who was in the room and their caregiver about their fall risk factors. And ultimately, what we saw at 6 months is that we really had high uptake of the recommendations that PT made. So something around 70% of the recommendations that PT made were either fully or partially accepted, which is wonderful. So even though it was a short consult, 20-minute consult in the emergency department, it really did have impact.
I love that. I'm interested to see how the larger study turns out, and hopefully to be a part of that when you come to Colorado. I have another question for you about the ASAP recommendations about geriatric emergency department accreditation. Have you been part of that at all? What are your thoughts on that program?
I think it's really wonderful that ASAP is pairing with geriatric emergency medicine researchers and other scientists to say, you know what, we have pediatric emergency departments. That model is so essential to provide high quality pediatric care. Let's make sure we also offer something similar for our older adults, because we know that population is growing. We know that we can do a better job with geriatric patients than we're currently doing, and it takes some support. So kind of inherent in this ASAP geriatric ED certification is that you get the buy-in from the C-suite, from other hospital leaders, to say, the certification matters. We're going to offer the resources necessary to provide this higher level of care for geriatric patients. And so I think it was a really smart move by ASAP, and I think it really will move the needle in terms of improving geriatric emergency care. We've implemented a lot of the recommendations at our clinical sites, including having PTs available in the ED, having pharmacists available in the ED for these patients, having the assistive devices that are necessary. So even though we don't have the certification, we've taken a lot of steps to move towards it.
Yeah, I hope that most emergency departments will at least move towards the primary recommendations, even if they're not able to move towards full accreditation. What are some of the biggest mistakes that you see emergency department providers making when they're interacting with the older adult population?
Yeah, I mean, I think most ED doctors and APPs are trying to do the best by all of their patients, but there really is a different approach to geriatric patients. And I think we're still very much in a mindset where we treat the 7-year-old the same way that we treat a 40-year-old. And the fact is that older folks have more cognitive impairment. They have higher risk for falls and serious trauma. There, are a lot of end of life considerations, and we really should be having, more scripted and thoughtful conversations surrounding end of life, given the type of work that we do. And then there's a slew of geriatric syndromes like delirium. Delirium is really under-recognized in the emergency department
100%.
setting. Elder abuse.
Yes.
Fortunately, we're starting to do some research there, but I think the majority of elder abuse and neglect cases are still being missed. So we have a lot of work to do. And I think that is going to involve not just ACIP geriatric certification, but also the work by a lot of aging interested clinicians and scientists that work in this emergency setting and get it. They get how fast paced it is, and they understand how to develop interventions in that setting.
I think that's absolutely a big area that we need to address. One of the biggest issues that I find is that when I have a patient referred to me for a fall that's an older adult, I'm always told, like almost always told, it was a mechanical fall. It was a mechanical fall. No, they're fine. It was just a mechanical fall. I need you to just go in and take a look. It was a mechanical fall. It's often not just a mechanical fall. I can think of one patient who, when I was interviewing her about and receiving her history and discussing with her, based on the information we had in the chart and going over that with her, are you still living with your husband? Is he still helping you out at home? No, my husband died 3 weeks ago. Oh, how have things been going since then? Well, I haven't really been eating or drinking anything because I'm sad. And he hasn't been able to go, and he was the one who did the grocery shopping. And so this woman actually was like passing out and falling. It wasn't a balance issue. It wasn't like an instability issue. It was like depression and lack of self-care and like just true despair. So, I mean, my intervention for this patient was to call her family and the social worker and hold her hand for a little while she cried, because she was just in so much despair. So I think trying to find out from patients why they think they're falling. Every once in a while, I'll have an older adult that's like, I think it's the 6 shots of tequila I have while I watch the night show. And I'm like, yeah, I mean, it could be that. I mean, that could be that, and so I think just like investigating a little bit more closely, instead of when patients say, oh, well, I tripped on something, it's often not that simple. Or they'll say, this patient should be able to go home. They just had a mechanical fall. But it's not that simple, particularly if the patient is a walker user, or they have 32 stairs to get into their house, or they really are like completely on their own and not thriving. So I think we all, when we're receiving histories from the patients in the emergency department, need to be a little bit more comprehensive and thoughtful about the questions that we're asking the patient. And I find the most helpful question is, why do you think you're falling? And I think that can make a big difference.
I agree. I mean, some of the things I talk to our residents about is just getting rid of the term mechanical in any of their charting or conversations, because there actually has been research looking at, compared to in patients where we charted mechanical fall versus non-mechanical fall, were the outcomes better for patients with mechanical falls? And the truth of the matter is no. These patients with falls, they have high morbidity, mortality, and follow-up, and most of the time that label of mechanical just makes us feel better that we don't have to do an extensive workup on them,
right.
but it actually doesn't bear out in the research to be more benign. So that's one point. The other point that I love and that you brought forward is the question about setting. I think one of the questions we should really start with is, what is your living situation at home, and who supports you at home, and do you have what you need to do your activities of daily living? And it's shocking how many times I go into the room and as an attending, and I just ask that one simple question, and it's very clear then what the disposition is. It's very clear who can go home and who can't go home and what they need at home. But that's a step that's often forgotten by our newer learners. And and then it adds several minutes, hours to their visit because we didn't ask soon enough, and so we haven't started to work on that discharge plan.
I think the other thing that I see in a lot of documentation from other healthcare providers is, their strength is documented, maybe their sensations documented, like all of these things are documented. And then under gait, it says too unstable for ambulation or too high of a fall risk to ambulate in the emergency department, safe to go home, and I'm like, well, okay, if you're not willing to get the patient out of bed, then I think maybe they shouldn't be going home, that's kind of a red flag. And so I've had that conversation with a few people, and now the change is, if you feel like that patient is not safe to get up with you, then please make sure you're calling the physical therapist.
Yes, that's a really, really valid point. And I think in general, we don't do enough gait testing. It takes a long time. It takes a long time to get a person that's just fallen, especially, or someone that's pretty frail out of bed. And the ED hallways in general are rife with environmental hazards. So
Oh, the whole
it's no
department,
easy
right?
task.
The gurney height,
Yeah.
the like lack of assistive devices, like to find a gait belt is a thing, to like feel comfortable doing that too. And I also
Mhm.
strongly feel that you need to assess vitals before you mobilize a patient as well. So I think that just lends credence to why physical therapists are so necessary in the emergency department, because you don't have time to do that.
I'll just tell just a little anecdote. When we were training research assistants to enroll patients in our study, and one of the things we do is gait testing of these fall patients. We had one of our lead physical therapists come in and do just train the research assistants in how to appropriately get someone up and out of bed and to gait test them. And I learned so much from that half an hour training session, and that was despite having worked in the emergency department and gait testing people for 10 years. So
I love it.
that's a recommendation I think that we can generate out of this podcast is, really have PTs teach you even these basic things, because it turns out we
Yes.
don't do that in medical training.
I think staff training is another huge benefit that we can add in the emergency department for sure. We need to give a lecture to residents about back pain, to our APPs about differential diagnosis of dizziness. So I think that's just another like safety and fall prevention. I was on the falls committee for many years to help make sure that we were reducing falls in the department, because it's a huge area of fall.
Mm-hmm.
I want to ask you, if you're a physician managing an emergency department, you're an administrator and you're looking for ways to improve your department, and somebody suggests having physical therapists in the emergency department, what would you say to them?
I mean, what I always say, which is that PTs are really essential, and their scope of practice can be quite great. I mean, in some departments, they can order X-rays. They can also tell ED clinicians that X-ray is probably not necessary, that this is a sprain. They're real experts in musculoskeletal pain and mobilization, also discharge planning. And I think they're essential to the care of older adults and after trauma. So yeah, I would not want to work in an ED anymore that didn't have a PT.
Oh, you are going to love it in Colorado. And we can order imaging in Colorado. So welcome. It's going to be great.
Excellent.
We can order imaging. It's a direct access state. We provide dry needling in our emergency department. So lots of services that we can provide. I love that reassurance to hospitals that are considering having a physical therapist. So on this podcast, we always end with a case. And because the theme of the podcast is admit it or not, because one thing that PTs help with in the emergency department is decreasing unnecessary hospital admissions. The flip side of that is sometimes we actually do push for admission. So can you think of a case where you had to involve the physical therapist?
I have an interesting case that actually didn't involve a physical therapist and shouldn't have. And I just think it's really important to look behind the scenes of what happens when you don't have physical therapy there. So one of our trial participants that was in the control and didn't see a physical therapist came to emergency department. She was about in her late 70s, lived with her husband in a single family home. And she had fallen and had what we call like this foosh injury. So she'd fallen onto her outstretched hand, and she fractured her distal radius, and we splinted her in the emergency department, and she was discharged home. And then we followed up with her, and a couple weeks after that, we met with her in her home and actually did a qualitative interview about how she was doing. And she told us that she's essentially lived in the same pajama for
Oh
since she's left the
no.
emergency department, because it was so hard for her to figure out how to get her pajamas around this cast, this splint that then turned into a cast that was made for her distal radius. And then she told us another really scary and sad thing, which is that in the past she was, really enjoyed the arts in Rhode Island, and she went to a museum recently, and she was too scared to go into the middle of the room. She was really scared that she was going to fall again. She developed this really terrible fear of falling that was impairing her ability to like enjoy life, because she
Mhm.
could only hold on to walls, and she was scared to go more than 1 or 2 feet away from walls. And I was just thinking to myself, it's such a shame, because if she had seen an occupational therapist or a physical therapist in the emergency department, they probably could have prepared her for, like, this is how you take off your shirt when you have a splint, or
Yeah.
these are the kind of clothes you wear, and this is how you can get around. And you have an increased risk of falls now, but these are the things you can do to prevent that. So I thought that was kind of a sad story, and lends support to the fact that what we do in the emergency department, if we do it well, can really impact a person's life.
I think one of my favorite things about being a physical therapist, and I probably say this way too often, is being a hope bringer and giving people their life back. We may not be like saving people's lives in the like traditional emergency department sense, but I like to think we save a lot of the quality of their life and
Hmm.
we give them that freedom back, because that breaks my heart. That absolutely breaks my heart to hear that. My favorite thing are second first steps, when you get people up for the second first set of steps after a traumatic injury, after stroke, after prolonged illness. And getting this woman back out into the community would be like such a blessing for her.
I agree.
Well, I truly appreciate you spending time with us today. I thank you so much for the research that you're doing and your advocacy for PT in the ED, and I cannot wait to collaborate with you going forward.
Thank you so much for having me. This is great.
I appreciate it. Thank you so much.